Assalamu alaikum. This is Rofjana. Today I will discuss management of suspected ovarian mass in premenopausal women. Previously, I have uploaded a video about management of ovarian mass in postmenopausal women. So there are some similar points, and obviously few points are different. So for the, I just want to revise few points so that you can correlate between two managements. I have mentioned when there is any cyst in the postmenopausal woman, how can we it present? Sometime there is a torsion and acute management, acute pain in the patient, so a patient is managed surgically to remove the torsion or cyst accident. And another scenario is in some investigation was carried out for investigation of some other gynecological reason like uh, uterine bleeding. So when you do the ultrasound, you see there is ovarian cyst. And third scenario is you investigate the patient for some non-gynecological reason like appendicitis or um, any other cause like some colon issues, some intestinal issues, and some whatever other causes are. So you do investigation and you see there is an ovarian cyst. So these are presentations. So whenever there is an ovarian cyst in the postmenopausal woman, we want to make sure that this is not a cancer because um, um, in this age group, there's a high incidence of cancer. So first, the management of the risk of cancer is different between premenopausal and postmenopausal, but we try to exclude cancer in both groups. So we ask in the history about weight loss and change in appetite and any irritable bowel symptoms which were developed after 50 years of age. So whenever, and if on examination we see these ascites, we can refer the patient immediately to the cancer center for the ascites and ovarian mass. Then we will see that we will, if the patient is giving vague symptoms and there's a cyst, then we will do two investigations, CA125 and TVS. We just need these two investigations. We will calculate the CA125 and we will do investigation to see there are any suspicious sign on the TVS. And if the cyst is large enough, then we can, that it cannot be fully evaluated in the TVS, then we can use transabdominal ultrasound just to supplement the information received by TVS. So then we will calculate the risk of malignancy index. And if it's less than 200, the patient is having low risk of cancer. If RMI is more than 200, there is increased risk of cancer. So we will manage accordingly. So in this patient, we will, when there is a suspected ovarian mass in the premenopausal woman, although the incidence of cancer is very less in this group, but still we want to rule out because if ovarian cyst is there, maximum what can it do? If it's benign, it can be enlarged, it can cause pressure effects, and it can, obviously it can have emergency situation like torsion and rupture. But when there is a cancer, we don't want to waste time. We want to immediately refer patient to the cancer center so that the prognosis is good. If it's obviously ovarian cancer has disadvantage because there is no proper screening method for this type of cancer. So whenever we diagnose it, often this cancer is in advanced stage. So we just want to detect ovarian cancer as early as we can. So in this patient, management of suspected ovarian cyst, first we will discuss the incidence. The overall incidence of asymptomatic ovarian cyst in the premenopausal female being malignant is approximately 1 in 1,000, increasing to 3 in 1,000 at the age of 50. These incidences are important because they can come as a multiple choice question in the part 2, part 2 MRCUG and FCPS. Up to 10% of the women will have some form of surgery during their life for the presence of an ovarian mass. In the premenopausal woman, almost all ovarian masses and cysts are benign. Almost all. So 10% of the suspected ovarian masses are ultimately found to be non-ovarian in origin. This is also another question. The underlying management rationale is to minimize patient morbidity by conservative management. We have the three options if there is any, we see the ovarian cyst is there. We can manage by three ways: by conservative management where possible, and we can use laparoscopic technique because we want to reduce the morbidity if everything is normal. Still, we do want to remove the cyst, simple cyst of large size, and there is no sign of malignancy. We can use laparoscopic technique instead of laparotomy because it can laparoscopy decrease the risk, decrease the post-op pain and fever, and also it can shorten the hospital stay of the patient, and patient can return to routine life earlier than laparotomy. Because now enhanced recovery program is being followed. For purpose of enhanced recovery program is that there less burden on the healthcare system. We can reduce the cost and the burden on the healthcare system wherever we can without compromising the patient safety. So in some future videos, I will add this topic as well. So third is the referral to gynecological oncologist where appropriate. So whenever there is a benign cyst, we can manage conservatively or by laparoscopic technique. And if there is a sign of malignancy, we will refer the patient to gynecological oncologist. Many ovarian masses in the premenopausal woman can be managed conservatively. Because I will make another slide, another presentation regarding type of ovarian cyst. Benign ovarian cyst. Normally, benign ovarian cyst can be functional, like corpus luteal or the follicular cyst, and they can be normally there are three structures in the ovary. We know that mainly where cancer arise. One from the egg, germ cell, like germ cell tumors. And second is the stromal, sex cord stromal tumor, and third is epithelial tumor. So, and for another is a functional tumor, functional cyst like follicular cyst and the corpus luteal cyst. So, functional or simple ovarian cyst, thin walled cyst without internal structure, which are less than 50 mm maximum diameter. It is less than 50 mm, less than 5 centimeter. Whenever it's is 5 centimeter, it will its management will be upgraded. So when it is less than 5 centimeter maximum diameter, usually resolve over 2 to 3 menstrual cycle without the need for intervention. We don't have to do any intervention, and we will not even follow this cyst if it is simple and it's less than 5 centimeter. This should be the sign of simple ovarian cyst. If surgery is indicated, a laparoscopic approach is generally considered to be the gold standard. So types of adnexal masses in the premenopausal woman, they can be benign ovarian and benign non-ovarian, and benign, they can be malignant ovarian and malignant non-ovarian. So benign ovarian are functional cysts, endometriomas, serous cystadenoma, mucinous cystadenomas, and mature teratoma. Adenomas are all benign, and like cystadenoma are benign, and cystadenosarcomas are malignant. So here we are discussing the benign ovarian cyst. Benign non-ovarian, there are the paratubal cyst and hydrosalpinges and tubo-ovarian abscess, peritoneal pseudocyst, and appendiceal abscess, diverticular abscess, and pelvic kidney. As I have mentioned before, the 10% of the cysts which were thought to be ovarian in nature, when we investigate, they comes out to be non-ovarian. So primary malignant ovarian tumors are the germ cell tumor. As I have mentioned, the 3 layers where can tumors arise: germ cell tumor, epithelial carcinomas, and sex cord stromal tumor. In the germ cell tumor, we have mature teratoma, immature teratomas, and epithelial we have serous cystadenocarcinoma and mucinous adenocarcinoma. And in the sex cord stromal tumor, we have granulosa cell tumors and theca cell tumors. Basically, these tumors are hormone producing, which are sex cord stromal tumors. So secondary malignant ovarian are the predominantly breast and GI carcinomas. As I have mentioned that in the post management of ovarian cyst in the postmenopausal woman group, also that there are benign causes and malignant causes, but there are also borderline ovarian tumors. Borderline ovarian tumors are mainly epithelial tumors, and these are type of tumors which are malignant, but their basement membrane is not invaded. So on the pre-surgery investigation like TVS and CA125, we cannot diagnose the borderline ovarian tumor before surgery. This is basically histological diagnosis. So whenever we remove the cyst and which appears to be simple, but it's not reducing or it's increasing in size, then when do the laparoscopic surgery, we see on histological analysis, we see that this is a borderline ovarian tumor. Once we have confirmed that this is borderline ovarian tumor on the histology, we will refer this patient to the gynecology oncology unit. So it is important to consider borderline ovarian tumor as a histological diagnosis when undertaking any surgery for ovarian masses. And when such a histological diagnosis is made or strongly suspected, referral to a gynecological oncology unit is recommended. Although up to 20% of borderline ovarian tumors appear as simple cysts on ultrasonography, the majority of such tumor will have suspicious ultrasonographic findings. Mean survival time for women with ovarian malignancy is significantly improved when managed within a specialized gynecological oncology services. So it's very important to diagnose early and to refer the patient to the proper place. Like if there's a risk of cancer, we are anticipating that we will refer the patient immediately to the gynecological oncology services. Hence, early diagnosis and referral is important. So in the history, when we see that this patient is a premenopausal patient, and we know that in the premenopausal woman, a lot of cysts are, almost all the cysts are benign, but this is still there is a risk of cancer. So we want to make sure in the history that patient is having cyst, and if it's malignant in any form, we feel that it can be malignant in the history or in the examination or investigation, then we will refer this patient to the cancer pathway. So a thorough medical history should be taken from the woman with specific attention to risk factors or protective factors for ovarian malignancy. That we can and a family history of ovarian or breast cancer. As we know, there are certain things which increase the risk of cancer, ovarian cancer in the woman. When there is increased ovulation, whatever causes increased ovulation, there is a risk of ovarian cancer, like early menarche, late menopause, but these are not having menopause, but still the OCPs, combined hormonal pills, are protective for the ovarian cancer. In this age group, young patient who have ovarian cancer, here majority of the patient have family history of ovarian or breast cancer. They can be the carriers of BRCA genes, BRCA1 or BRCA2, or the Lynch syndrome. So if their patient already diagnosed having these genes running in the patient or in the family, then we will take this into consideration when we are deciding about the cyst being malignant or benign. So we will also ask in history about symptoms of endometriosis, because CA125 can also be raised in endometriosis, and in the endometriosis there can be endometriomas which can appear on the ultrasound as ovarian cyst and along with some solid components. These are called as chocolate cyst. So and also endometriosis is associated with some malignant cancer as well, like endometrioid cancer and clear cell carcinoma. So endometriosis plays on both sides. So we will ask patient about the symptoms suggestive of endometriosis and should be specifically considered along with any symptoms suggesting possible ovarian cancer, ovarian malignancy. Persistent abdominal distension, appetite change, including increased satiety and pelvic or abdominal pain, increased urinary urgency or frequency. On examination, we will do the careful physical examination. And as we know that the examination is 15 to 51% sensitive, the poor sensitivity for ovarian masses. And examination should include abdominal and vaginal examination and the presence or absence of local lymphadenopathy. In the acute presentation with pain, the diagnosis of accident to the ovarian cyst should be considered. Torsion, rupture, hemorrhage can be there if there's a large cyst and it's rotate. And although clinical examination has poor sensitivity in the detection of ovarian masses, 15 to 51%, its importance lies in the evaluation of mass tenderness, mobility, nodularity, and ascites. So this is also another question, that how much clinical examination can diagnose ovarian masses. So now we have taken history examination and what test should be performed. So as with the, we know that in the postmenopausal, we only need CA125. In the premenopausal group, if we see on the TVS that it is a simple cyst, then we don't have to do any other investigation, no matter if its size is 5, 6, but it's clearly simple cyst. So we will not do any serum blood test, just in if there is no any other warning things like family history of cancers or weight loss or these things pointing to the malignancy. So if everything is normal and on ultrasound is appear as simple ovarian cyst, we will not do anything, any blood investigation. A serum CA125 assay does not need to be undertaken in all premenopausal women when an ultrasonographic diagnosis of an simple ovarian cyst has been made. So lactate dehydrogenase, alpha-fetoprotein, and HCG should be measured in all women under age 40 with a complex ovarian mass because of possibility of the germ cell tumor, because germ cell tumors occur in young age. So if we see any complexes, we will also do these tumor markers. So CA125 is unreliable in differentiating benign from malignant ovarian masses in premenopausal women because of increased rate of false positive and reduced specificity. I have mentioned these false positive and false negative in the postmenopausal group as well. But in the postmenopausal group, most of these conditions does not occur, like endometriosis and other things. There are less incidents as compared to premenopausal group. So CA125, which increase non-malignant condition, which increase the CA125 level, like pelvic inflammatory disease, fibroid, acute events in benign cysts, for example, torsion or hemorrhage, endometriosis, high values are reported in Caucasian compared with African or Asian women. It is CA125 level can be decreased due to caffeine intake, hysterectomy, or smoking. And non-malignant condition affecting CA125 level, any condition which can cause peritoneal irritation can increase the CA125 level. So benign non-gynecological condition that cause peritoneal irritation, tuberculosis, cirrhosis, ascites, hepatitis, pancreatitis, peritonitis, pleuritis, other primary tumors that metastasize to the peritoneum, breast, pancreas, lung, and colon cancer can also cause and elevate CA125. So this is about CA125.